Good afternoon, Dr. Band and classmates. This is Marcia Sawyer. I'm pleased to share my comparative analysis of Denmark and Sierra Leone's health systems. This presentation is part of our International Health Systems course. Over the next several slides, I'll explore how political, economic, and cultural factors shape healthcare delivery in both countries, and how these factors influence access, quality, and overall health outcomes. I selected Denmark and Sierra Leone because they represent two different settings. Denmark is a high income nation with a universal tax funded healthcare system, while Sierra Leone is a low income country still working to rebuild its health infrastructures following the Ebola epidemic and also COVID and years of civil conflict that has been going on in my country. My goal today is to highlight the lessons that each country can learn from the other, particularly in promoting equity, strengthening the health workforce, and improving governance to enhance population health outcomes. Now that I've shared the overall purpose of this presentation, let's take a closer look at what we'll be focusing on. As mentioned earlier, this comparative analysis explores two different types of health systems, Denmark and Sierra Leone. As we fondly refer to Sierra Leone, Saloon, the purpose of this comparison is to understand how income level and governance and health infrastructure influence the way each country delivers care. More specifically, I'll be examining several key focus areas: equity, access to care, health, financing, and workforce capacity. These elements are central to understanding not only how systems function, but also how they promote and sometimes limit health outcomes across population. Finally, I want to emphasize the global relevance of this comparison. Even though Denmark and Sierra Leone are on opposite ends of the income spectrum, the challenges they face, such as maintaining equitable access, funding sustainability, and workforce development, are shared across many health systems worldwide. With that framework in mind, let's move into the country's profile to better understand the demographic, socioeconomic context that shape each nation's healthcare system. Now that we've outlined and Now that we've outlined the purpose and global relevance of this comparison, let's turn our focus to the specific context of Denmark and Sierra Leone. As illustrated earlier, as illustrated in this table, the two countries are differ significantly in income level, population, health, and system structure. Denmark is located in Northern Europe. It's classified as a high income country with a population about 5.9 million. It maintains a strong, stable economy with GDP per capita of roughly 75,000, and citizens enjoy a life expectancy of 82 years, one of the highest globally. Denmark allocates about 10.4% of its GDP to healthcare, funding its universal tax-based system that guarantees access for all residents. Sierra Leone, by contrast, is a low income West African nation with an estimated 8.8 million people. Its GDP per capita is approximately 2,000 and life expectancy averaged 61 years, reflecting the lingering effects of civil conflict, the Ebola epidemic, and resource constraints. Infant mortality remains high, about 70 deaths per 1,000 live births, compared to Denmark's rate of 3 per 1,000. These figures reveal how economic strength and governance influence population health. Denmark's decentralized regional model supports efficient resource allocation and preventative care, whereas Sierra Leone's centralized structure, while improving, still depends heavily on a donor funding and external aid. Collectively, these contrasts illustrate that a country's wealth, political stability, and administrative structure directly shape the capacity of its health system. What proves effective in one setting may not seamlessly transferred to another, yet valuable lessons can still be shared. With this background in mind, let's move forward to examine how each system is organized and financed and how these arrangements arrangements affect access, quality, and sustainability of care. Building on the country's profile we just reviewed, let's now look more closely at how each nation system is organized and financed. Understanding structure and funding is essential because it directly shapes who receives care, how services are delivered, and how sustainable each system is over time. Starting with Denmark, the country operates under a universal tax funded model that provides coverage for all legal residents, and approximately 85 to 90% of total health expenditures are financed through public taxation. The system is decentralized across 5 regions responsible for hospitals, specialized care, while municipalities handle preventative and rehabilitative services. This regional governance model supports local decision making and promotes efficiency through efficiency, though it can create variation in care quality between regions. Denmark's emphasis on strong primary care gatekeeping and electronic health records ensures continuity and coordination of care. However, despite its strength, the system faced persistent challenges such as rising healthcare costs and increasing wait times for elective procedures. In contrast, Sierra Leone, my native country, follows a mixed financing system that remains heavily dependent on external donor funding, accounting for about 60% of total health expenditures, with government contributions making up roughly 30% and private out-of-pocket payments covering the remainder. The system is centralized government governed by the Ministry of Health, which coordinates policy, financing, and district level administration. The Free Healthcare Initiative, introduced in 2010, offers cost free care to pregnant women, lactating mothers, and children under 5. While this has improved maternal and child health indicators, gaps persist in workforce capacity, infrastructure, and medical supply chains. From a personal perspective, growing up in Sierra Leone has given me firsthand understanding of how these structural challenges affect care at the community level. The country is made up of many distinct tribes, each with its own regional center or local capital. For example, the national capital, Freetown, is historically governed by the Creole tribe, but as the population diversifies, governance structures are also shifting. Recently, the federal government has proposed dividing Freetown into 2 administrative areas, reflecting both demographic growth and evolving dynamics of governance. These nuances remind us that public health policies are always shaped by social and cultural and political realities, not just economic ones. This lived perspective reinforces how donor dependency and centralized control intersects with cultural diversity and governance in shaping health outcomes, strengthening local capacity, community trust, and equitable resources distribution remains critical for Sierra Leone's health system to move towards long-term sustainability. As we transition to the next slide, we'll see how many differences in finances and organization translates into measurable health outcomes, workforce capacity, further illustrating each system's strengths and ongoing challenges. Now that we've explored Denmark and Sierra Leone's structure and finance their health system, let's turn our attention to how these differences translate into measurable health outcomes and workforce capacity. As shown here, the contrast between the 2 countries is striking. Denmark's life expectancy averages 82 years, reflecting both a strong preventative care model and universal access to services. In contrast, Sierra Leone's life expectancy is 61 years, which while improving, still reflects the lingering effects of resource limitation, post-conflict recovery, and disease burden. Similarly, infant mortality offers a clear indicator of health system performance. Denmark's rate stands at only 3 deaths per 1,000 live births, whereas Salon's remains around 70 per around 70 per 1,000 of the highly global of the highest globally. These numbers reveal the combined impact of healthcare access, maternal education, and infrastructure stability. Turning to the workforce indicators, Denmark has 45 physicians and 100 nurses per 10,000 people, supporting timely care and comprehensive coverage across the population. Sierra Leone, by contrast, has only 2 physicians and 13 nurses per 10,000 people, illustrating a severe human resource gap that affects both rural and urban health care delivery. From a personal perspective, as someone native to Sierra Leone, these workforce disparities are not just numbers. They represent the reality of communities where a single nurse may serve multiple villages, or where specialized care is available only in large cities like Sierra Leone. Like Freetown. Despite these challenges, Salon's health professional demonstrates incredible resilience and dedication, often working with limited resources to deliver life-saving care. The comparison also underscores broader global patterns. High-income systems like Denmark's face sustainability and aging population issues, while low-income systems like Sierra Leone focus on accessibility, capacity building, and donor coordination. Both, both must innovate to sustain progress and ensure equity. As we move to the next slide, we'll explore the key challenges and lessons learned from both countries, what Denmark can teach us about effective universal care, and what Sierra Leone's resilience can teach us about adaptation, equity under resource constraints. As we've just seen from the comparison of health outcomes and workforce capacity, differences in structures and resources naturally lead to very distinct challenges for Denmark and Sierra Leone. This slide summarizes those challenges and highlights what each country can learn from the other. Beginning with Denmark, one of the most pressing issues is the rising cost of healthcare, which continues to place financial pressure on both the government and taxpayers. The nation also faces increased waiting time for elective and specialty procedures, a common issue in tax-funded systems that aim to provide universal access. Additionally, Denmark's aging population presents a growing demand for chronic disease and management and long-term care services. These challenges, while complex, arise largely from the success of maintaining longevity and universal coverage. On the other hand, Sierra Leone continues to navigate infrastructure limitations, health workforce shortages, and restricted access, especially for rural communities. Many health facilities still operate with insufficient equipment or staff, and distance remains a significant barrier for those living outside of urban centers. As someone who was raised in Sierra Leone, I've witnessed how structural challenges affected communities at the grass levels. In rural district, one clinic may serve multiple villages, and access to consistent maternal and child care often depends on donor support and mobile health outreach. Despite these constraints, Sierra Leone's system demonstrates remarkable resilience and community engagement, with healthcare workers continuing to serve under resource limited conditions. When viewed together, both systems offer valuable lessons. Denmark's decentralized governance and digital infrastructure illustrates how organization and technology can sustain equity and efficiency, while Sierra Leone's adaptability and community-centered response model shows how resources limited country can build resilience and public trust. Both both systems emphasize that achieving health equity is not solely about income, it's about policy commitment, community partnership, and system adaptability. As we move to the next slide, we'll examine the global implications of these findings, connecting both nations' experiences to the broader goals of World Health Organization and the United Nations Sustainable Development Goal 3, good health and well-being. As we've just discussed the key challenges and lessons from Denmark and Sierra Leone, this final slide brings those findings into a broader global health context. Both nations, despite vast differences in income and infrastructure, offer valuable insights that align with global pursuit of equity, efficiency, sustainability in healthcare systems. On this map, we can see Denmark and Sierra Leone connect through shared themes of collaboration and mutual learning. Denmark's experience demonstrates how strong governance and digital health integration and preventative care can sustain high performance and universal access. Sierra Leone, meanwhile, represents resilience in the face of adversity, showing how community based models and external partnerships can extend healthcare to even the most resource constrained settings. These lessons tie directly to Sustainable Development Goal 3, which calls for ensuring healthy lives and promoting well-being for all at all ages. Achieving this goal requires global collaboration, sharing innovations from systems like Denmark while investing in capacity building, workforce development, and infrastructures in nations like Sierra Leone. From a personal standpoint, as someone whose roots are in Sierra Leone, whose academic and professional experiences have extended internationally, I view this comparison as more than theoretical. Sorry for being choked up. It highlights the importance of bridging worlds, leveraging lessons from high-income countries while empowering local leaderships and communities to adapt them meaningfully within their own context. Ultimately the global implication is clear. No health system operates in isolation, whether through data sharing, capacity building, partnerships, or global financing frameworks. Collaborations remain essential to strengthening resilience, promoting health equity, and achieving universal coverage. In conclusion, both Denmark and Sierra Leone remind us that sustainable health systems depend not only on wealth, but on governance, community trust, and the shared global commitment to equitable care for all. In conclusion, I'd like to take a moment to acknowledge the key sources that support my analysis. This research and comparison shared through this project was grounded in credible data from global institutions such as World Health Organization, the World Health Organization, the World Bank, the Organization for Economic Cooperation and Development, and the Sierra Leone Ministry of Health and Sanitation. These sources provided a balanced foundation for the understanding how health systems in both Denmark and Salone are shaped by economic governance and culture. These two images shown here represent more than geography. They reflect identity and meaning. On the left, the Nyhavn harbor in Copenhagen captures Denmark's organization, stability, and social cohesion, qualities mirrored in its universal healthcare system. On the right hand is the Cotton of Freetown, Sierra Leone. It stands as one of the most treasured symbols of a national freedom and unity. The cotton tree was believed to be the oldest in Salone and holds deep historical and cultural significance. According to legend, its gained importance in 1972 when freed enslaved people settled in what is now Freetown and gathered beneath the tree to give thanks for their freedom. The settlers and their descendants became known as the Creole tribe. The cotton tree stood at the heart of the capital for over 2 centuries. Sadly, this sacred tree caught fire in May 24, 2023, marking the loss of a national and spiritual landmark. Although I was not born in Sierra Leone, I was raised there by my paternal grandparents, who instilled in me the connection to the country's history and resilience. Watching the Watching our cotton tree grow weaker over the years broke my heart, and seeing it burn was truly devastating. For me, it was more than a national symbol. It was a living piece of my family's history, a reminder of the strength and hope that defined Salone Sierra Leoneans. That personal connection reinforced one of the most important lessons of this project, that health and resilience extends beyond system and policies. They are also about identity, history, and shared community strength. Before closing, I want to sincerely thank Dr. Band and my classmates for taking time to engage with my presentation. These two countries may differ greatly in resources, but both demonstrate how governance, equity, and community can shape population health. If you have any questions or reflections or thoughts, please feel free to contact me at msawyer@purdue.edu. I'd be happy to continue the discussion and share additional insights from my research. Thank you again for your time and your thoughtful attention, and for allowing me to share not just an academic comparison, but a personal story that connects history, culture, and public health.